Psychiatry is a branch of everyone. Talk about gastroenterologists, they see depression cases more than us with somatization. General physicians, definitely. Surgeons, and there are a lot of patients who do a lot of doctor shopping. Almost 50% of depression have onset between 20 to 50 years, most productive years of any person's life. A depressed person, if you crack a joke, if the severity of depression is high, they will not laugh. And usually this is a matter of practice. I do this when I'm examining. I try to crack the joke whatever I can. If the patient smiles, the mood reactivity is present. In atypical depression, mood reactivity is present. So sometimes, even the other physicians feel this is not depression, but mood reactivity is just a sign. This sweets, it's not the chocolate. It carries a temporary mood lifting neurotransmitter, and that is called anandamide. Okay. So sometimes, people binge sweets, desserts, they temporarily cause the betterment of mood, but it immediately falls. Many times, whatever we spoke in meeting, we forget. Sometimes we call somebody, we also forget. Why did we call? But why this is not dementia then? Why we are labeling it depression? Hello, good evening, everyone. For the topic which is close to everyone's heart, I believe all of us are doctors, and some or other way, I personally feel psychiatry is a branch of everyone. Talk about gastroenterologists, they see depression cases more than us with somatization. General physicians, definitely. Surgeons, and there are a lot of patients who do a lot of doctor shopping. Okay, so how are we going to recognize who is in need of help? There are a lot of patients, who are referred by cardiologists, gastroenterologists, physicians, surgeons, all possible branches, where they feel, it's not their cup of tea or something which is going beyond the organicity. Somebody presenting with, classical features of depression, it's very easy to manage, right? I'm not having any interest in anything. I'm having, mood issues. I'm not able to sleep, having disturbed appetite. But when the presentations are varied, okay, then, it could be a challenge. But a good physician can possibly diagnose or can sense something is getting wrong, and an early referral can save a lot of issues for patients, as well as the treatment challenges also. So let's go ahead with this topic: depression, one illness and many faces. So many things could be already known to you. You all people are very learned, but just a humble attempt to address what I find significant. So, what is going to be the outline? Statistics and demographics of depression. Why this topic is important for us? Risk factors when we talk about depression. Diagnostic criteria. This is common for anything. Case scenarios, possibly, which we all can relate to, of varied presentations of depression. Presentations in spatial set of population, how it differs in children, how it differs in elderly, how it differs postpartum, and approaches and treatment, just a brief about it. Why this topic is important for us? The lifetime prevalence of depression worldwide is 15 to 20%, quite high. Globally, more than 264 million people across all ages suffer from depression, and unipolar depression is considered as second leading cause of global disability burden by 2020. This was WHO. Twice to thrice common in women. Multiple reasons: biological reasons, hormonal reasons, learned helplessness model, societal reasons. Although no age is immune for depression, almost 50% of depression have onset between 20 to 50 years, most productive years of any person's life. Okay. And this was the study done by Azucham in 2018, which caused an alarm. 42.5, almost half of the employees in Indian sector, who are working in private sector, were afflicted with either generalized anxiety disorder or depression as compared to government employees. And all of us, we deal with corporates. So why this is important? The lesser pay scale, more working hours, more drain, which happens in private employees. So, the statistics with the point of view of, depression is very important for us, as most of the patients, who are in the age group of 20 to 55, working class, more working in private sector, women, and yes, it's most important, global disability burden. The depression is carrying the most important burden for global disability. Now, the risk factors we all know genetics are childhood adversities, certain personality types. Talk about, borderline personality. Talk about the anxious personalities. These are more prone for having depression. Addictions make you more prone for depression. Many times, where we see there are no reasons. Obviously, everything is going very nice in life. But why patient goes through depression? Yes, sometimes endogenous factor, effect of hypothyroidism, various hormonal issues, various medications taken like steroids also can cause depression, or sometimes we cannot figure out any reason also why this happens. Being females itself, is a risk factor for depression. But what we are talking, these are risk factors like any other major medical disorder. Talk about cancer, talk about diabetes, talk about hypothyroidism, talk about heart attacks. There are risk factors, but risk factors necessarily don't mean that they will cause depression, as each person is different. So these are risk factors, but they are not the causative things for depression. What exactly happens in the brain? The typical chemical locha. All of us are aware about it. Final common pathway is same, the neurotransmitter issues, what we are typically seeing. Initially thought when we were students in MBBS, it's the norepinephrine. Later came serotonin. Later came the interplay of many neurotransmitters. Talk about glutamate, talk about glycine, talk about dopamine, okay, and what not. But what exactly happens? Either the levels are low or the brain doesn't sense it. We are very much aware about the chemical locha. I'll not go in detail about it. Just we are touching the brief before we touch the case scenarios. Diagnostic criteria. In typical case of depression, which none of us will miss, individual must be experiencing 5 or more symptoms during the same 2-week period. Minimum 2 weeks period, 5 and more of the below mentioned symptoms. With either depressed mood has to be there, or loss of interest in previously pleasurable activities. Whatever the person used to enjoy, patient used to enjoy, not enjoying, and depressed mood for maximum time, maximum days. While we are talking maximum time, maximum days, a depressed person can also feel happiness, but once the stimulus is withdrawn, the person goes for low mood. And markedly diminished interest in pleasure in almost all activities. Okay. Now, minor criteria: significant weight loss when not dieting, or weight gain, or decrease or increase in appetite almost every day, slowing down of thoughts and reduction in physical movement. What we are talking about, time to understand fatigue or loss of energy almost every day. If we see 20 cases of depression in a day, almost 18 agree, 18 in fact present with, I'm not left with any energy. Feelings of worthlessness or excessive or inappropriate guilt every day. Diminished ability to concentrate, focus, indecisiveness almost every day. And recurrent thoughts of death, suicidal ideation without a specific plan, or a suicide attempt or specific plan for committing suicide. The eighth criteria indicates a big severity. It directly puts the patient in severe episode. So, to receive the diagnosis of depression, these symptoms must cause individual to go through some socio-occupational deterioration, like not able to maintain uh, what we typically say the social relations, or difficulty in functioning occupationally, and must not be result of any substance abuse or other medical condition. Okay, so classical case will present with this. But what we are going to discuss today are atypical scenarios, okay, where the presentation could be different, but a nice clinician can diagnose. Not so typical cases, but atypical cases, but very typical depression. So let's go with the first case. Different, but still the same depression. Sneha, a 20-year-old woman, made a visit to psychiatric clinic by herself. Nobody took her. With the complaints of sleeping almost 8 to 10 hours a day, had gained more than 5 kgs in 3 months, constant craving for carbs, being eating desserts and fried foods, and had difficulty in controlling the urges. In fact, she said she used to feel good temporarily by binging on the high calorie foods. By the way, are you aware? This sweets, it's not the chocolate, it carries a temporary mood lifting neurotransmitter, and that is called anandamide. Okay, so sometimes people binge sweets, desserts, they temporarily cause the betterment of mood, but it immediately falls. But later she felt guilty, report certain heaviness in the body for hours together. I feel that my legs are heavy, my hands are heavy, irritation and crying for petty issues. Her family members told her she had no self control and discipline, and that's why she is gaining weight. Because of weight gain, she was sleeping a lot more and often feeling lethargic, leaving her all the more irritated. On mental status examination, what we found, she had low mood, high irritability, loss of interest in previously pleasurable activities, tiredness for full day. Food was just not a matter of interest, it was a compulsion. By the way, we typically say in psychiatry, exercise is the most underutilized antidepressant and food is the abused one, right? And the same was true for uncontrollable sleep. It was a matter of compulsion. Self blame, hopelessness, and loneliness feelings were there. She was sleeping and eating well. How she can be depressed? This was the atypicalness for depression. Her family members wondered, Doctor, you are saying she is depressed, but she is eating well. She is sleeping well. She can't be depressed. This in turn made her, nobody understood her, felt more hurt upon listening to the remarks of her dear ones. What is this? What we are dealing with? Atypical depression. A normal depression case will present with difficulty in sleeping, losing a lot of weight, okay? But here in atypical depression, as the name suggests, it is atypical. This is characterized by reversal of vegetative symptoms. Instead of sleeplessness or appetite loss, the patient experiences excessive sleep and increased appetite along with weight gain. And what is something, hindrance, why the patient doesn't directly come to us, referred by other doctors also, sometimes mood reactivity is preserved. What we mean by mood reactivity? Okay, a depressed person, if you crack a joke, if the severity of depression is high, they will not laugh. And usually this is a matter of, practice. I do this when I'm examining, I try to crack the joke, whatever I can. If the patient smiles, the mood reactivity is present. In atypical depression, mood reactivity is present. So sometimes, even the other physicians feel this is not depression, but mood reactivity is just a sign. If you ask about the other symptoms in detail, all the features of depression are eventually revealed. And many of us might be knowing, what this heaviness in the hands or legs could mean. Leaden paralysis. This is another symptom of atypical depression. Coming to other case, pain behind a smile. Okay. A friend and colleague of Vikas Bhatt, a 45-year-old gentleman working in very high post in MNC, observed changes in him since 6 months. So this case was brought by his friend. He was brought by that friend to psychiatry OPD. The friend observed, although Bhatt completed his work efficiently, attended office parties, and interacted with everyone formally, somewhere he appeared lost. They didn't go to play to tennis. They didn't go to play tennis on weekends, which they used to enjoy before. So it was just a hint that something is wrong with his friend, what prompted him to bring. He was meeting his deadlines, okay? He was attending the office parties, but some spark was missing, as per the friend. During our conversation, the patient agreed he had to push himself for everything, as every task felt like a burden. Although he was meeting all deadlines, he was taking but more time to do them. So he had to put extra effort to finish the work. He was not showing it, but he was losing interest in previously pleasurable activities. The friend noticed he is not coming for playing tennis. He had started questioning the purpose of majority of the life events. He did not come to meet a mental health care provider, as he thought he will be able to overcome it of its own. Now, by the way, the differential diagnosis in this case was, even the empty nest syndrome or, the climacterium, what happens at the 45 or midlife crisis. But ultimately, on inquiry, what came was smiling depression. How it is different than classical depression? Classical depression, the patient will come with, depression. Here, smiling depression, we need to see the pain behind that smile. Okay, what is happening? So, although the patient suffers from depression, he appears very happy and satisfied outwardly. He has minimal problems at his jobs or relationships, but that doesn't mean he is not suffering. Such patients hide their sufferings very well when they are in public and make it seem as if everything is fine with their life. But in fact, depression is taking a major big toll on their life. Also, they have to put the extra effort than usual to keep the concentration at work, to meet the deadlines, and maintain social and family relationships. Most of the time, okay, it's not the patient who comes to meet us, it's a close relative or a friend can still understand the difference in the person in terms of what they were before and how they are now and bring the patient to us. So, smiling depression, they are still smiling, they are able to meet the deadlines, but there is a pain behind that, there is an effort behind that. They are not really enjoying, somehow they are able to meet the ends. But a close person to them can just see the changes and can make out this smiling depression. No drama, but a call for help. Sunita, a middle aged woman, was referred to psychiatry OPD after undergoing extensive investigations in the neurology OPD for the features suggestive of fits or seizures. We have seen such cases, definitely. Nothing was found on investigations. When we asked the patient few questions, we came to know such episodes have always happened in front of people, never happened when the patient was alone or when patient was slept. The patient never injured herself during such episodes. There was no tongue bite, there was no frothing, no soiling of clothes also, okay? And these episodes were precipitated by some tensions in the family. The patient appeared depressed, stressed, and this was her usual response to intolerable stress. So many times, the patient present with some sort of organic symptom. And what we are seeing here, it's not a drama but a call for help. Depression presenting as hysteria. Okay, so hysteria episodes, they usually never come to us. Sometimes a patient is complaining, I'm not able to see from one eye, seizures, okay, one leg I'm not able to lift. So we often see patients who get bouts of seizures, who say suddenly they are not able to see through one eye, there's excruciating pain near abdomen or something. The relatives usually feel it's a drama. They being dramatic, no doubt about that, as it happens always after stress, but that's far from the truth. It's not the drama. It's basically, a cry for help. In fact, for any underlying hysterical episode, there is always a psychiatric condition. Usually it's depression. So what happens? What exactly happens when hysteria happens is the unconscious split. Okay. Whenever you are undergoing the intolerable stress, the mind goes for unconscious split and patient develops such kind of symptoms. Sometimes, the loss of voice also. That also happens when hysterical episodes happen. So they do it unknowingly. They don't do it consciously. In fact, if we tell it's a drama, the symptoms worsen. How we handle, we try to understand the need, okay, why the person is doing this. And when we understand the need, 99% of the time, hysteria is outwardly presentation. Inside, there is depression. There could be psychosis also, but 99% it's depression. Once we address that, better coping mechanisms develop. Once we go ahead with family therapy and medicines, patients usually recover. So when we address their concerns, their depression with compassion, they are able to handle the stress in a better way. I forget a lot. How many of us face this problem? Even I forget a lot. So, a Prasenjit, a 30-year-old man, visited our OPD. He was working in a software company as a project manager. For a couple of months, he had been having difficulty in remembering certain things discussed in meetings. He would often forget simple stuff where he has put glasses, keys, or mobile and was wasting a lot of time finding them. Lately, he had even forgotten what he was seeing in meetings and had to take some time to orient himself again. This had happened not just once but twice. His project deadline was approaching and he had not been able to sleep for the last few weeks and even had difficulty in focusing. He was feeling low in confidence and had low energy levels. He was really worried about the future as his performance kept deteriorating. On further inquiry, we found he was fulfilling all criteria for depression, although the concerning symptom for him was only forgetfulness. So, what is this? So many of us go through now. Many of us go through basically something what we call absent-mindedness. So, what this person presented with? Difficulty in remembering simple stuff. Why he got worried? Because he zoned out. So many times, this happens to us also. We ask patient 2 times a question, a single question, maybe 3 times also, but we are not able to register. Okay, we also zone out. Many times, whatever we spoke in meeting, we forget. Sometimes we call somebody, we also forget. Why did we call? But why this is not dementia then? Why we are labeling it depression? First, look at the age and rest of the symptoms fulfilling depression presenting as pseudodementia. So pseudodementia condition not only happens in depression, that's not the only cause for pseudodementia. We also see pseudodementia happening in hysteria. Okay, what is the difference in true dementia and pseudodementia of depression? Most important, the age of onset, what we are typically seeing, and other features. So the patient complaint, usually who are having forgetfulness as depression patient, they complain for routine things. They may feel they are experiencing the true memory loss or dementia. So many times, the patient come to us with forgetfulness. In depression, there is no actual memory loss. Doesn't happen. What we see is absent-mindedness. The patient is so self-absorbed due to depression, they don't even register many things. That's why there is no recall. So when you don't register only something, there is no question of recall. If I tell you, I have kept something over there, please look at it. Self-absorbed somewhere, there is no question of forgetting, no question of recall. Nothing registered, no question of forgetting. But the patient will give you most important part, the details of their memory loss. Even my mother says this, my boss says this. Even sometimes I ask patient, they are also not able to, they are whatever they say, I'm not able to register. So they will give you the details of memory loss, and they are very concerned as they know they are not doing well in their socio-occupational sphere and feel great deal of distress. Okay, so in pseudodementia cases of depression, a person will be bothered about the memory loss, will give you all details about the memory loss, right? But how it differs from dementia patient? A dementia patient will never be concerned about their memory loss. Confabulations, right? In fact, they are not even aware of their memory loss many a times. When you check the memory, immediate, recent, remote, sometimes they confabulate. Okay, you ask what you had for lunch. If a depressed person is not recollecting, they will get distressed. In dementia patient, they will confabulate many times. Oh, I had this. Okay, it could be momentary confabulation where they just feel the gap. It could be fantastic confabulation. They will add some colorful memories in it. Okay, and sometimes if you make them realize that you are not remembering, and if they realize they are not remembering, what we see is catastrophic reaction. They just throw the temper tantrums. True dementic patient, this will never happen in depression case. Other symptoms of depression can be found on inquiry. In depression, pseudodementia, there will be no major incidents of forgetfulness. Okay, like forgetting home address. You will see dementics, they are just roaming around. They forget the address, or forgetting the identity of important people in their life. This will never happen in depression. The onset of forgetfulness in dementia is very slow, very insidious. When we talk about depression, it starts very, very abruptly, right? I occupy one pole of this swinging disorder. What we are talking? Bipolar. Dhriti, a 20-year-old college student, had the history of overfamiliarity, reduced sleep, excessive spending, and bragging. Her mood would swing from happy to irritated without any stressor prior to this behavior. She was brought to us by her parents as she was in mania. This was happening since 10 days as we began talking, and she was unstoppable. It was found she was unstoppable. Once she began, she said she knows her PM and has big contacts, that she had some special powers, and people are jealous of her because of her beauty and intelligence. She had started smoking a week back. We found out she had the history of depression 1 year back and had responded to antidepressants very well, which she was still taking. She also had the family history of depression in mother. What possibly we are dealing? Switch, okay, which had happened, the switch of polarity from depression to mania, which sometimes happens in bipolar 1 patient. Bipolar 2 can also have, but more probability with bipolar 1 patient. Okay, there was a family history positive for mood disorder. There was a history of depression. She had responded very well. And the history is suggestive of mania, talking big things. She was unstoppable, pressure of speech, having big talks. And this was the mania presentation. Probably the switch had happened after antidepressant, but which proves the diagnosis of bipolar 1. So depression as one pole of bipolar, also one needs to identify why we are stressing in different case scenarios. Whenever somebody has bipolar, the manias are treated very well, okay, but the depressions are not treated very well. They are never taken seriously in medical circle also, because the patient is quiet, okay, let him be quiet, okay, as is not disturbing. But the suffering is real even when the person goes through depression also. So bipolar 1 is characterized by mania, which has symptoms like expansile mood, excessive happiness, boasting about oneself, decreased need of sleep, very high energy levels, over familiarity, excessive talkativeness with strangers, novelty seeking behaviors like promiscuity and excessive spending. She also started smoking. This was also part of novelty seeking behavior. The other pole is depression, which has all features of classic depression, which we started in the beginning. In between two poles, the patient is totally asymptomatic and normal. Okay, this is as opposed to chronic depression, where the patient could be depressed for years. Okay, but in bipolarity, what happens? If we are happy, we are happy to this extent. If we are sad, we are sad to this extent. Mania, full blown expansile state, depression, the classical state, but inter-episodic total recovery could be there. Now, as opposed to popular belief, after mania there should be depression, after depression there should be mania. No, alternately it may not happen. There could be mania after mania after mania, total recovery. There could be depression after depression and total recovery. The episodes can last for months without treatment. Can untreated mania come back to normal without treatment? Yes, it usually comes down within 3 months, even if you don't treat. But patients show improvement in matter of few weeks with proper treatment. Okay. Bipolar 2 characterized by depression for years together, and most of the times, if the relative is vigilant, there could be the episode of hypomania. We are all aware in medicine, hypo means small mania. Once in a lifetime or twice in a lifetime in bipolar 2, you will see hypomania. Mania depression cycle is much more common in bipolar 1. Now, the mind causes physical pain. Another case scenario of depression, which all, general physicians could be seeing this. Sudha, a 45-year-old woman from a lower middle economic strata, came to see us after many physicians and surgeons asked her to meet a psychiatrist for her symptoms. For the last 2 years, she had been having on and off back pain, abdominal pain, bloating, headache, tightness in the shoulders and neck. Many of you could feel this could be fibromyalgia, this could be chronic fatigue. Yes, it could be. She also had tingling and numbness in both hands and feet, sometimes felt a burning sensation while passing urine. She reported she had been feeling weak and sick for a very long time. She said she was raised by a dominating father, and now her husband, who works in contractual job, was also very demanding and dominating. She felt neglected by her husband, had been working tirelessly since her childhood. Although the physical work was not really expected from her now, she felt drained by simple household tasks too. Her two kids were attending college in another city, was qualifying the criteria for depression when we put the clinical criteria. So what is happening here? You can see four pains happening since last 2 years. Okay. You can see some pseudoneurological complaint happening. Okay. One urinary or, gastrointestinal complaint happening as well. Okay. And also she is meeting the criteria for depression. So here what we are seeing, depression presenting as somatization. We see many people with undiagnosed pains in the body or with troublesome symptoms which are not explained by medical science. Okay. In fact, one of our senior psychiatrists, a teacher used to say, medically unexplainable all symptoms happen in anxiety. And we all of us have experienced at least one or two symptoms in our lifetime, which are not explainable by medical science, but they do happen. They are very real. They visit multiple doctors for the pen, undergo several tests, nothing comes of it. Finally, they take a call to visit a psychiatrist. On inquiry, we find all features of depression, but those are never patient's primary complaints. Also, it's important to note in the country like India, it's easy to get treated for headache or body aches than to talk about, depression. Don't you think so? Periphery, it may not be very easy to talk that, I'm stressed. They might tell you that, why don't you become mentally healthy? Why don't you try some, why can't you become so strong? It's easy to tell, I have some physical symptoms. Now, the mechanism for pen in depression is multifactorial. Just imagine, this is just an activity we can do. From head to toe, just scan your body. Okay? Head, neck, shoulders, chest, abdomen, thighs, knee, legs, foot. Maybe come back, shoulders, arms, forearms, and hand. What you saw, there could be some infirmity somewhere, there could be some stiffness, there could be some pain also. As long as we are not depressed, the pen which is 2 on 10 will appear 2 on 10. If we are depressed, the pen which is 2 on 10 will go directly to 10 on 10. Okay, so this is one mechanism for depression. Second, we definitely know the norepinephrine mechanism for depression. This is the pain, getting hormone. Also, there is substantia gelatinosa of Rolando, and there is, nociception pathway. When you are depressed, these pathways gets activated, and low levels of norepinephrine in depression can also contribute to pain symptoms. But the best part, both depression and pain respond very well to antidepressants. Here, we use the different antidepressants. Predominantly, we use TCAs, we use desvenlafaxine, we use duloxetine in such scenarios. Coming to, our last case, what we are talking, those temper tantrums are a sign. Murlidhar, a 75-year-old patient, was brought to us by his relatives. For the last 2 months, he had been taking bouts of anger every 2 to 3 days. He was having even more frequently against the caretaker. In these 2 months, 2 caretakers had left the job because of his extreme irritability, his temper issues. He was not sleeping properly. He was also drinking more frequently in the evenings. When his relatives refused to give him the drinks, he would often get even more irritated. Although he was eating properly, the day before the consultation, when he was brought to us, he had thrown his food outside the window in the fit of anger as he found it very tasteless. He was found sobbing twice or thrice in the room in last 2 months. They reported no issues with the memory. Why we are talking about the memory, look at the age. Sometimes even dementia can present with BPSD, behavioral and psychological problems. On talking with patient, we found him to be uncooperative initially. He was not brought with his will. We spoke little about tennis, which he used to watch regularly till few months back. Gradually, he opened up about his feelings. We found that new caretakers were unable to understand his needs. There were language issues with the patient, making him even more frustrated and lonely. He could not sleep. Alcohol helped him to sleep. That's why he asked for it every day. He said of late constipation was really bothering him. The feelings of frustration and helplessness even triggered the anger more. What we are seeing here, agitated depression. Here the classical, low mood may not be in presentation. These patients, they come to us, if they come to us directly for the anger management, but sometimes even relatives bring us, the spouse bring, or, sometimes their boss asks, you need to have the psychiatric consultation. But behind his anger spells, often, negative emotion, dissatisfaction, and frustration with life are seen. Much more common in males, the males depression typically presenting with, agitated depression, reckless driving, having more risky behavior than, typically the sadness of mood or crying, maybe due to societal attitude. Many patients who go through depression may go to the shell, but some express the depression through aggression and anger. This is agitated depression. In fact, this is a routine for us to evaluate all patients referred to us for anger management, for depression, as well as this is the major cause of agitation. Many times when you ask the patient why you are getting angry, sometimes they say, I'm not able to handle the stress. Sometimes it's just a misplaced emotion from anxiety. As I'm not able to handle the life, this happens as a part of misplaced emotion, and behind this there could be depression. So we saw different case scenarios. We saw smiling depression, we saw depression presenting as hysteria, we saw agitated depression, we saw depression as somatization, we saw atypical features of depression. Whatever I could think, I tried to present. Now depression presentation in spatial set of population, so affecting different population. In children we don't see the classical features of depression. Younger children may present with regress behavior, like they may start passing urine in the bed, they may start crawling when they go through depression a stage prior. Older children may go through school refusal, they may have variety of pain symptoms without the cause. They may have frequent nightmares, poor scholastic performance, high irritability. In severe cases, we even see the growth could be retarded, physical growth could be retarded. Teens also don't present with classical features of depression. They may present with social aloofness, addictions, reckless and risk-taking behavior, sleep and appetite disturbances, anger outbursts, and maybe self-esteem issues. Here, not to be confused with identity crisis. Identity crisis is a normative crisis which happens in teens, and it will never demand, it will not have the classical features of depression, only rebellious attitude, but the teen will not have the significant features of depression. The elderly, they may present with poor self-care, self-neglect, multiple body pains, lack of interest in the routine, may be accompanied by restlessness, fearfulness, sometimes psychotic features, like fixed false belief that world is coming to end, all their money is stolen. So many times the patient present with this, that my money is stolen by either mates or by my relatives. Postpartum period, I'll show just talk about this last case. 32-year-old lady Priyanka was referred by gynec for lack of sleep, refusal to breastfeed the baby, angry, aggressive behavior with her family members. The patient would either cry or get angry for most of the time, shouting often. The child was not wanted and she would never become a good mother and wanted to die. She delivered the baby 1 month back. It was her first child, boy baby. Initially, the family thought it was happening due to baby blues, but everything getting worse rather than getting better. And then they realize possibly this is something bigger, and the gynec referred the case to us. Baby blues, almost 80 to 90% of the ladies go through this. This is the transient low mood, happens due to the sudden shift of hormones, shift of circumstances, and additional responsibility. Barring tearfulness and little lows and absent-mindedness, most of the time no other symptoms of depression are seen, and the baby blues disappear of their own within 2 weeks without treatment. Okay, only support and psychoeducation is the treatment offered, and these are often given by elderly women in the family. Postpartum depression is entirely different entity. It's considered bipolar equivalent now. It needs to be addressed immediately for the sake of safety of the mother and baby both. Almost 10% of the women experience it, and it should be suspected when the baby blues get stronger and don't go away within a couple of weeks after delivery. What are the symptoms? Severe mood swings, irritability, lack of bonding with the baby, feelings of inappropriate guilt. In fact, self-harming and the baby harming ideas can also happen, and there could be the history of mood disorder in the patient as well as in the family. Condition needs to be treated by psychiatrists, and it can be managed very well. Menstrual cycle changes. Almost all of us go through it. 75 to 90% of the women in the premenstrual phase have it. Associated with the feelings, with the heaviness in the body, bodily symptoms due to water retention, pain in the breast, breakouts on the skin, cravings for sweet oily food. Psychological symptoms like excessive irritation, low moods, reduced sleep, and crying spells may happen. These symptoms happen why? Because fall in the estrogen level, and limbic system is full of estrogenic stimuli. Wherever estrogen goes low, serotonin has to follow. So both issues happen. General PMS symptoms, how do we treat? More walk off, exercise more, low salt diet helps. Primoza oil for bodily symptoms of PMS. PMDD, much severe. Okay, full criteria for depression, starting 7 to 10 days prior to periods and getting released once the periods start. Requires antidepressant, even pyridoxine is proven of some use. So approach at the end for depression. A good clinical interview definitely helps for the patient and the family. Sometimes, if relevant, we do psych testing, investigations like thyroid profile, CBC, B12, vitamin D in some cases. I don't do it in general cases. Neuroimaging if you suspect some organicity in addition to depression. Management depends on the patient profile, patient choices, how often the patient wants relief, patient's preferences. Comorbid issues also you need to take in account. Severity of the issue. Talk about the mild depression. Yes, we treat with diet and exercise. Talk about moderate to severe depression. This amygdala hijacks the prefrontal cortex. This prefrontal cortex is responsible for judgment, reality testing. Everything gets impaired. So when we say love is blind, love is actually blind, but so is depression, so is anxiety, so is anger, any extreme of emotion. Counseling cannot act. We need to use medical management for some degree of time. Expectations from the treatment also matter, and course of the illness. Having recurrent symptoms, recurrent depression issues, in addition to antidepressant, we need to use mood stabilizer. Having severe course, we may have to use ECTs or ketamine also. Management, exercise, diet, lifestyle changes do matter. Counseling, yes, the most effective therapy. Cognitive behavior therapy. How do we use? Cognition means thought, behavior, obviously, what we say, and emotions are all interlinked. Okay. So we address the behavioral part and the cognition part, and emotional part automatically uplifts. There are other kinds of therapies. There is REBT, there are client centered therapies. Most of us, what we use in addition to medicines are called eclectic therapies, little from here, little from there. Medications, antidepressants, benzodiazepines, mood stabilizers. Still we know what we learned, and we still can use what we typically say, thyroxine and lithium in resistant depression. Yes, even androgens some people have used. Nowadays we don't use androgens. ECTs in severe cases. Newer modalities, recurrent transcranial magnetic stimulation, vagal nerve stimulation do have some role. Ketamine I personally use a lot, and it is found to have very, very good effect, both what we use as parental route and oral route. At the end, what we typically say when we talk about atypicalness of scenarios, let's read between the lines, listen to what is not spoken, see what mind is talking via bodily symptoms, and understand the pain behind the fake smiles. After all, what William Osler has spoken, a good physician treats the disease and a great physician treats the patient who has the disease. We have to be in other category. Thank you all for patient listening. Thank you. If there are any question answers, any feedbacks, let us take it forward. Thanks.
Thank you so much for that very illuminating presentation. We do have some doubts coming in from our doctors, and we'll be getting into that. So, highlighting the question on the screen, ma'am, the first question was from Dr. Kulkarni. How is depression different from hysteria and schizophrenia? Please enlighten.
Okay. Fine. So, what we are talking, depression, basically the psychopathology. Okay. When we talk about it's a neurosis. Okay. Schizophrenia is a psychosis. Now, in neurosis, when we are talking about hysteria many a times, what we typically say is a presentation outwardly. Behind hysteria can also be there something. Okay. Now many a times people confuse hysteria with schizophrenia. Both are different. Let me distinguish hysteria with dissociative disorders also, which I have not spoken over here. So depression, first let me clarify, it's a neurosis where the insight is not gone till the extreme of depression. Okay, when there is a severity of depression, at that time we get some delusions called nihilistic delusion, like world is coming to the end, my all money is stolen, or there is no point in life, I'm hearing the voices, commit suicide. So these are nihilistic delusion. But otherwise depression is a neurosis where patient will come himself or will have some insight. One. Second, when you talk about hysteria is a split. Okay. So conscious and unconscious mind, there is a split. Okay. Some intolerable stress is happening. That's a coping mechanism. I'm not able to see from the eyes, but the patient is not aware this he or she is doing it willingly. They don't do it willingly. Okay. Now behind hysteria, there could be something. 90% of the time there is depression, but 2 or 3% of the time there could be something else like psychosis also we have seen presenting with hysteria. So hysteria usually is a presentation. How do we treat hysteria? Okay. Usually we have to treat the underlying condition. Now coming to schizophrenia. Schizophrenia is a psychosis, it's a thought disorder. Okay. And what is happening here? Loss of touch with reality. Depression, neurosis, where insight is there, touch with reality is there. Psychosis, there is no touch with reality. A person imagines fixed, false, unshakable belief, not keeping with socio-cultural norms. You are spying behind me. People are talking about me. Without evidence, they will think. Hallucination may or may not be there in schizophrenia. Those are, not to be confused with this. Now, let me talk about dissociative disorder also, which nobody has spoken. But sometimes people feel dissociative disorder and schizophrenia are one and the same thing. If I'm lucky in my career, I'll possibly see one or two cases of dissociative disorder. Otherwise, I'll not say. Till now, I have not seen a dissociative disorder case. Dissociation, what happens? Very similar to hysteria, but at deeper level, identity is only different. Okay, let me give the example of Bhul Bhulaiya 1. Okay, here the Vidya Balan, they have depicted so beautifully not only the dissociative disorder, but the psychodrama also, what Akshay Kumar does at the end. So here the identity is itself different due to lot of stress. There could be dissociative identity disorder, there could be dissociative amnesia for a typical event like sexual abuse. Sometimes there could be dissociative amnesia. And the third, dissociative fugue, a person can be at some other place taking different identity. Okay.
So, ma'am, going to the next question.
Yes.
It is another question from Dr. Kulkarni, sir.
Okay.
Okay, highlighting on the screen. Antidepressant and central stimulant drugs, do they have the same mode of action?
Not really. Okay. So antidepressants, when you ask about, there are only two antidepressants which have little stimulant action. One is fluoxetine and the other is bupropion. Okay. Now, if you ask, fluoxetine also gives little dopamine in the prefrontal cortex, and bupropion is NDRI, okay, norepinephrine dopamine reuptake inhibitor. So they do have something to do with dopamine release, but it's not the exclusive mechanism for the antidepressants. Okay, so fluoxetine will have some mechanism with serotonin and plus dopamine. Okay, NDRI bupropion will have something to do with norepinephrine and dopamine. But stimulants, when you are talking, we are talking about, methylphenidate, we are talking about mood alert. Okay, these are the stimulants what we are talking. They are directly acting on the dopamine pathway in a specific circuit. Okay, so stimulants have direct role on dopamine. By the way, when you ask about which caused the shift, we spoke about the switch. Okay, the antidepressants like fluoxetine, bupropion will say still lesser probability than direct stimulants which are pushing the dopamine in the circuit. Okay, so stimulants directly acting on the dopamine pathway, whereas antidepressant, they have other mechanisms also and little dopamine push, not the direct. Okay, otherwise we would have preferred those in ADHD cases, right?
The next question from Dr. Madhav. What is the etiology and pathogenesis of depression spectrum?
Spectrum. Okay, when we are talking about depression spectrum, as I started, in the beginning, there are risk factors. We cannot figure out the direct etiopathogenesis, like major medical disorders. Talk about heart attack, talk about cancer. We know the risk factors. Okay, we cannot point out this is the causative thing. So we started with that, first slide. These are the risk factor. Talk about genetics. Yes, one of the important factor, we have some chromosomes, some loci, okay, which are responsible. But there is a role of epigenetics also. Not everyone who is having that will have depression. There are, certain personalities which are prone for depression, childhood adversities. But again, what I'm saying, these are risk factors. Not everyone who goes through child abuse or early loss of parent will have depression. Addictions are responsible to a certain extent. Okay, being female gender, that puts us, 2 to 3 times more prone for depression. Okay, much more. And family history, definitely more than genetics. So these are the risk factors. But when we talk about the final common pathway, so I couldn't put the slide for it as these were the scenarios. So there are different circuits, and the neurotransmitters affected in different circuits are different. So dopamine, when you talk about, nigrostriatal pathway has a different role, in the frontoorbital cortex has a different role. But what I typically say, serotonin, okay, the major culprit neurohormone, what we are talking neurotransmitter. But yes, the other also play the role, and there is an interplay. Okay, so you are talking about somebody who is having retarded depression, we are going to use antidepressant with serotonin and dopamine. Somebody who is having pain symptoms, serotonin plus norepinephrine. Okay, so we are going to decide, what are the causative things. Somebody who is having, lot of vomiting issues. Okay, NASA, norepinephrine serotonin antagonist with 5-HT3. So multiple, pathways are there, but the final common pathway when you are talking, it's, at synaptic level, the issues are happening. We know what exactly happening at final common pathway. Either the neurotransmitters are not recognized, or they are not available at the synaptic level. So most of these are reuptake inhibitors, okay, or acting at antagonist level. Hmm. So beyond that, talking could be little difficult here, uh, because we can't show the pics, what exactly happening in the circuits. But there are different circuit, there are different neurotransmitters, and when you talk about the risk factors, these are only risk factors. We don't have the foolproof method, this causes this. Okay, these are just risk factors.
Next question from Dr. Ratandeep. What can be the major causes of depression in children?
Okay. Yeah. So what we mentioned, genetics do have the role. Secondly, we definitely say childhood adversities have the role. Third, we talk about the environment which is playing the major role. We don't have the supportive environment now. The nuclear families, you see, the loneliness thing is lot more. Okay, competitive atmosphere, which is a lot nowadays, which was not there at our times, is more. Talk about children who are less than 10-12 year old also. Okay, they are all computer literate nowadays. So talk about little older children, they are not getting attention on social media, could also be the cause. So when we are talking about, yes, the genetics do play the role, but more than that, I personally feel it's the environment, sometimes parenting, sometimes atmosphere, that can also add to the thing. Also, most of the preteens, what I'm seeing in Bangalore, they have taken weed at some or other point of time. Okay, and weed can lead to a motivation syndrome. At least there is a recreational use. Okay, so again, multifactorial, what we can express.
Next question from Dr. Shah. Less sedative antidepressants.
Yeah. So less sedative antidepressant, fluoxetine, excellent antidepressant. In fact, it is activating antidepressant. That's why we give it in the morning after breakfast. Okay. Another, bupropion, that works very well, as it is NDRI. We give it again in the morning. Talk about SNRI group. So serotonin norepinephrine reuptake inhibitors like desvenlafaxine, duloxetine. You can give it at any point of time. Most of the SSRIs, okay, serotonin. You talk about sertraline, you talk about escitalopram. There is an option whether you want to give it in the morning or at night. Paroxetine comes with 1+ sedation. Exceptionally sedating, you ask me, are the TCAs and mirtazapine. Beyond that, two super stimulating antidepressants, yes, fluoxetine is one of it, and bupropion could be other.
So there are some similar questions which we can maybe address together. So Dr. Aziz is asking drug of choice for depression. Dr. Santosh is asking, as a general practitioner, if you could guide us regarding prescribing some common antidepressants. Also, Dr. Dera is asking, kindly guide on how do we choose a particular antidepressant in a particular case, as there are so many different antidepressants.
So, I personally feel the first line, as per me, talk about any case, okay, except the kids. Children, we usually, I personally don't prefer escitalopram. Even now, there's a black box warning for all antidepressants. So let's talk about age group. Fluoxetine is super safe when you talk about kids, okay, PRODEP. So start with 20 mg, go 30. Another antidepressant, which you can take when the person is having a lot of anxiety, child is having, is imipramine. Okay, we use it for bedwetting, if you are aware, 12.5 to 25. So this is with respect to kids class. Okay, and why we are preferring fluoxetine, by the way, just not it is USFDA approved, but also it will activate the kid, it will improve the focus of the child. Okay, it will motivate the kid. This is one. The common question, 100 marks to one antidepressant as per me is escitalopram. Okay, Nexito, the popular brand. Okay, what people consider it much more popular. But why I prefer, escitalopram is having much more calming effect. Most of the depressed patient will have comorbid anxiety. Very gentle on stomach. Okay. Um, okay. When you talk about, most of the morbidities, talk about diabetes, talk about blood pressure, talk about thyroid, quite gentle profile, doesn't affect. Very, very safe. Okay, up to 20 mg, but basic dose to start is 5 mg, 10 mg, up to 20 mg. Till 10 mg, we usually say that even the non-psychiatrist should consider. After 10 mg, if you feel that you require better consult with a one consultation with a psychiatrist is okay. Now question, so whenever you see the retarded depression coming, when you feel the person is having retarded depression, not feeling active, feeling retarded, sleeping a lot, eating a lot, fluoxetine can be considered. Okay. And if you feel the person is having more anxiety features, you can consider escitalopram. Person who is elderly, having sleeping issues, having appetite issues, or somebody who presents with throwing up issues, miltazapine is another very safe option. Okay, it doesn't alter any salt level, anything, no hyponatremia. But how it's helpful, what we typically say when you talk about mirtas. So it will take care of all these things. Only one side effect, which is very bothersome, and as physician you should know, 7.5 mg causes more sedation than 15, than 30, than 60. At 60, sedation is gone. So when you are prescribing miltas for sleep issues, remember 7.5 is way more sedating than 30 mg. Okay, so we can go ahead with this. And one simple suggestion, whenever you are handling a case of depression or anxiety, for a short term, don't forget to add benzodiazepine. Okay, the anxiety cannot respond because our medicines take a couple of weeks. A short course, okay, not like alprazolam prescription for month together, but a short course can be of some help.
So next, Dr. Kanaga Durga is asking, is dysthymia curable?
Okay, when you talk about dysthymia, okay, usually is when we call something dysthymia, when somebody is having low grade depression for years together, not fulfilling the criteria for florid depression, but having low grade depression, what we typically say in Hindi, rooted personality. No matter whatever happens in their life, they are always unhappy. Okay, so cure, I would say dysthymia, by the way, was considered a personality type earlier. Okay, nowadays it is considered a low grade depression presenting for years. Yes, it responds very well to SSRIs, but when you talk about cure, no, I will not be able to say, because something which is lasting more than 2 years comes in chronicity with permanent changes. So a person can be kept happy, person can be very much at normalcy, provided they are taking the medicine. It's very much like diabetes, it can be kept very much under control with a fulfilling life. But if you ask about cure, no, cure I am not very sure.
Next, Dr. Swami says, ma'am, these days a lot of acute panic attack is happening in teen adults, also presented as depression. Are there any significant factors?
Panic attacks during teen adults also present yeah, anxiety does present. Okay, so when you talk about depression, till the depression goes to extreme level, when the suicidality comes, there is no anxiety at that point. Okay, but before the suicidality, when you talk about mild to moderate depression, anxiety is invariably there. Okay, if you see Hammy scale, okay, which are the rating scales for depression and anxiety, you will see 80% of overlap is there. And why anxiety happens, it's a protective response, something I'm not able to take in, something which is happening not so off good with me. Okay, so getting overwhelmed, getting not prepared. At extreme level of depression, the patient is at other end, they don't have anxiety. So panic attacks happening in teen adults, yeah, who are presenting as depression, definitely. And what we typically say, please try to find out relationship factors could be there in the teens. Okay, identity crisis could be there, and please try to figure out if there are any substance use behind. Okay, because most of LSDs talk about anything, party drugs, what they use, they can lead to panic attacks.
So next, Dr. Krishna Priya is asking, after menopause abstinence, will it lead to depression?
After menopause abstinence, what we mean from abstinence is from what? uh,
Dr. Krishna Priya, if you could elaborate on that. Meanwhile, could we go ahead with the next question? So there are a lot of similar questions on antidepressants that are safe during pregnancy and during lactation period. So addressing it together.
okay, so when we talk about which are safe in pregnancy and during lactation period, okay, Say if you talk about, there was only one antidepressant which was category B. Okay, as per US FDA during pregnancy and lactation period, it was bupropion. Now it's been degraded to C. But if you ask, I have used in more than thousands of ladies so far, who are pregnant, as my fellowship was in perinatal psychiatry. So none of the patients had any issue. If you ask, what are category D drugs, what not to be used in pregnancy, which is the antidepressant, I will say paroxetine. Never touch it. Okay. Again, the current consensus is not agreeing to it. Paroxetine can also be used. But if you ask about the safe during pregnancy and lactation, escitalopram is safe. Super safe registry with amitriptyline, okay, from the 1956. It's been used, it's very safe. If you ask what is my choice of drug when we talk about antidepressant in pregnancy, I will say escitalopram. Okay, if required, amitriptyline, but no benzodiazepines. Absolutely cross to benzodiazepines, absolutely cross to lithium, absolutely cross to divalproate. Those, even as mood stabilizer, we don't use. And something what we use, in pregnancy for anxiety is, phenargan, promethazine, okay, which is used as antiemetic also. That also acts as wonderful anti-anxiety. Okay, so only one antidepressant not to be used in pregnancy is, paroxetine. Newer antidepressants I'm not very comfortable, which have come just now, 10 years back, 15 years back. No, we don't have the safety data. SSRIs except paroxetine are super safe. TCAs are very safe, okay, in pregnant women. And for anxiety, no benzodiazepine, but promethazine is safe. Hmm?
Um, so I think we've already discussed it, but if you could just go through it again. Dr. Agarwal is asking TCAs versus MAOIs versus SSRIs, which group is to be given when?
Okay. Look, Mao, I personally, being psychiatrist, I'm absolutely not comfortable to give. I have used only in my residency period in Mumbai, JJ Hospital, because Mao, as when you have to give a lot of instruction to patient. Don't take this, don't do this, okay, and they cause serious reactions. Okay, so no to, Mao inhibitors. Talk about TCA SSRIs. Okay, SSRIs, normal depression, please start with as a first line drug. Talk about TCA, different pains in the body, having difficulty in sleeping. Okay, somebody who is having bedwetting issue, somebody who is presenting with little anxiety issue. Okay, still TCAs can be of some help. But if you ask, primarily when I use amitriptyline when somebody is having somatic complaints. Okay, clomipramine sometimes in OCD cases, and imipramine sometimes in kids who present with, bedwetting. Primarily drug of choice is usually SSRI. Okay.
Before proceeding, doctors, I would just like to ask, ma'am, is it okay if we take a few more questions?
Yes, we can take.
Okay. So coming to the next one, Dr. Aziz is asking, long-term use of Paxidep on also, is there any side effects?
Long-term use of paroxetine when we talk, or for that matter, any SSRI. Uh, Only one we are scared, barring weight gain and other issues, sexual issues. So sexual issues are totally reversible. By the way, 200% they are reversible. What paroxetine causes is premature ejaculation. Again, the sexual dysfunction, 200% reversible after stopping the drug. We use, in fact, this drug for premature ejaculation. This causes delayed ejaculation or sometimes ejaculatory failure also. Talking about only one side effect which could be bothersome in less than 2% of the people is SIDH, syndrome of inappropriate antidiuretic hormone secretion, and which is very, very rare side effect. Till now, I don't say I have not seen, but SIDH is way more common with, BP control medications, okay, which have the issues with sodium issues rather than our medications, but they do happen after 20 to 30 years of uninterrupted use and very well manageable SIDH with fluid restriction, with sodamine tablets. So for me, if you ask, SSRIs, usually, we don't put any red flags, when to stop, how to stop. Usually when the patient is all right, we stop within 6 to 8 months. But repetitive failure, soft bipolarity, generalized anxiety, we continue paroxetine for indefinite period.
So actually coming back to Dr. Krishna Priya's question, I think ma'am is referring to sexual abstinence. So after menopause, will abstinence lead to depression?
Usually, we don't say the sexual abstinence happens after menopause. In fact, most of the patients report after menopause the urge getting up. But many people are scared due to estrogen defense gone and the UTIs, which happen after the menopause. My patients at least tell. Talk about perimenopausal period, the depression goes quite up because of the lack of estrogen. Okay, and the perimenopausal last for period lasts for 2 to 8 years. It's not so small period. So at that time, if you ask, yes, the hot flashes talk about low estrogen, low serotonin does work. Post menopause, what we have studied, for 1 year, the prevalence of depression is little up. After that, most of the time, the people are able to move forward. Hmm.
Next from Dr. Suresh, antidepressant in fibromyalgia, patient is not responding to SNRIs.
Okay. So, usually what we say when you talk about fibromyalgia and SNRI, TCAs do work, 1 point. Franxit, if you have heard, one medicine, flupentixol mellitracin. So as I discussed, when we talk about fibromyalgia also, there is a medical mechanism, but when you talk about psychiatric issue, so overthinking is always there. Okay, there is a tenseness in the body when we are talking about it, and overvalued idea about the pen. A low dose antipsychotic with excellent anti-anxiety effect definitely works. So if not SNRI, you can add on TCA if you want to. Levosulfide works, and something called Franxit flupentixol with mellitracin. That also works very, very well in the cases of fibromyalgia. Mhm.
So Dr. Jain is asking next, antidepressant with least cognitive side effects, and also can imipramine be taken 100 mg per day lifelong?
So, antidepressant with least cognitive side effect. This was a recent discussion, and our biological psychiatrist, Dr. Bhaskar Mukherjee, he had spoken very nice thing. So, when you talk about cognitive side effects, okay, in fact, the antidepressant prevent from dementia. There are lots of papers, okay. So, when you talk about the rapid onset dementia, fast onset dementia, anti-inflammatory effect of almost all antidepressant, okay, that helps when you talk about the dementia and the inflammation which is happening at cellular level. Talk about least cognitive side effect, yes, the antidepressant which don't cause any sedation, usually don't cause any issues when you talk about processing. So less cognitive side effect, fluoxetine works, goes for the top, then comes sertraline. Can imipramine be taken 100 mg for per day for lifelong? Yes, why not? If the patient is tolerating, here the question is that 100 mg imipramine, if you ask beyond 50 mg, most of the patient talk about anticholinergic side effect, and most commonly dry mouth. If the patient is tolerating, yes, you can use. If the patient is not having urinary retention, patient is tolerating dry mouth, can be used, no worries. Hmm?
So doctors, in the
Recent
interest of
advances,
time, yeah.
in antidepressant clinical trial, yes, there are many. There are coming, lot. Opipramol is coming. Ketamine, I personally find very promising when you talk about antidepressant. Dextromethorphan and bupropion combination, which I'm using left and right in resistant cases. So dextromethorphan, as we all know, is a component of cough syrup, which causes, uplifting the mood. And they have combined it with bupropion, and 2 plus 2 is not 4, but 6 to 8.
Can maybe take the last 2 to 3 questions in the interest of time.
Okay.
So coming to the next question from Dr. Purohit, ma'am, if you could say something on treatment of postpartum depression.
Hmm. Yeah, so postpartum, when we spoke about, okay, PPD is usually considered an mood equivalent, okay, mood disorder equivalent, so bipolar equivalent. Postpartum depression talk, please involve the psychiatrist, we have to involve because of the severity, okay. Baby harming ideas could be there, self harming ideas could be there, and it's very, very severe. Usually, in addition to antidepressant, we have to add a mood stabilizer, okay. ECTs are super safe in postpartum period, and we have considered. But what is the thumb rule that you have to supervise the baby and mother? Never leave the mother alone with the baby. Never leave the mother alone, first of all. Second thing, please involve the psychiatrist. Third thing, what we typically say, in addition to antidepressant, we need to add a mood stabilizer. What is the current guideline? Not a mood stabilizer. We have to use antipsychotic with a mood stabilizing effect. Okay, during that period, don't stop the breast milk. Okay, but we need to do it under the supervision. And the fourth thing, ECTs can be considered, they are super safe. Okay, if the postpartum depression is severe. Okay.
Next question from Dr. Swami says, in younger patients, did antidepressants cause extrapyramidal symptoms post-weaning? Also, does this cause addiction?
In younger patient died they mean antidepressant causing extrapyramidal symptom post weaning. Look, I have usually, there were, tetracyclic antidepressant which can cause extrapyramidal symptoms like amoxapine or something like that. Okay, I have never seen extrapyramidal symptoms except TCs, for the logical reason can cause theoretical. But addiction, when you talk, I have seen addiction happening to aspirin also. So yes, each and every drug carries the risk of addiction. Whatever is acting on your reward circuit, whatever is acting on your comfort circuit, whatever is acting on your stimulant circuit, yes, it can cause addiction. Antidepressant can cause addiction, but what we typically say, under medical supervision, they don't. It's our responsibility, in fact, to take the patient out when the time is right. And I'm not very sure about the extrapyramidal symptom post weaning of the antidepressant, but I'll have to read about it. As long as my knowledge goes, tetracyclic antidepressants are known to cause extrapyramidal side effect, okay, due to their effect on certain pathway. But otherwise, I have not seen, but I'll read. Okay.
So, doctors, we are taking the last question since ma'am has already addressed a lot of the queries here. It is from Dr. Agrawal. Can you start with 12.5 mg of sertraline and then increase it gradually? Should you give it in the morning or at bedtime?
So if you ask, here also people differ. And 12.5 will be too less dose. I'll ask you to start with 25 until and unless a patient is very anxious to start with 25. Okay. Generally, we start with 50 mg, 25 to patients, who are having a lot of gastritis. Okay. I personally prefer to give it at night. Here also, the opinions differ. As I told, some medicines can be given in the morning or at the night, desvenlafaxine, sertraline, even acetalopram. I prefer to give it at night for the very much reason of gastritis. Okay. So initially it causes, the starting dose could be 25, and eventually, actually, you can increase it every 2 weeks till you see the desired response. First 6 to 8 weeks, the recovery graph is quite up. I'll suggest to go up to 50 at least to see the desired response. And I would prefer to give it at bedtime, but there is nothing hard and fast. Okay. It doesn't affect the dopamine levels. So you can give it anytime. It's not sedative also. Hmm? All right. Thank you. Thank you, everyone. It was a fruitful discussion.
So, doctors, ma'am has already addressed a lot of the queries. If you have anything and if we have missed out on anything, you can still post your questions under the flyer and at ma'am's convenience, ma'am can take a look. Thank you, ma'am, again for this wonderful session. Also, thank you for answering so many questions very patiently. It was lovely having you and really hope to see more of you on Medflix, ma'am. Thank you once again.